You're listening to Musings with Morales, brought to you by Dialysis Education Services.
Welcome to Musings with Morales. I'm Morales. Looking forward to a great discussion with Nurse Jaye, a special guest tonight. For everybody who has been with us, it's actually Nurse Jaye's first podcast.
It is.
So thank you for blessing us with the honor.
Unexpected podcast, honestly.
Unexpected podcast. So let's get into it, guys. I got to tell you that we've kind of been stacking up our podcast lately. We've had some really interesting guests, and it really got me thinking about choices and consequence or rewards of choices. You know, what I really wanted to get into tonight is, one, learn about you as a registered nurse, a master's in MSN, right? MSN. And then I know that we've kind of got a shared passion for people who have kidney failure and being able to administer different sort of therapies for them. So again, it's your first podcast, Nurse Jaye.
Yes.
Tell us a little bit about yourself, kind of how you became Nurse Jaye. So maybe who you are besides that superhero cape.
I've been a nurse since 2006. I started off as a LVN, eventually went for my RN and got it in 2010. So I decided to get my master's in nursing during COVID, actually, when everyone is like pretty much locked down.
Yeah.
It's Master's of Science in Nursing Education, pretty much, just to advance my degree. As far as experiences, I started off as at a nursing home as an LVN and eventually transitioned to outpatient clinic where we deal with family medicine, pediatric, basic nursing care pretty much. And then after that, I transitioned to inpatient nursing, so more of like hospital setting. So we did a new grad program as an RN and eventually just moving up pretty much. So I'm pretty much now at Kaiser doing stroke and peritoneal dialysis units. So
that's an interesting combo. So I want to get to kind of what the day in the life is as far as working in that sort of unit, inpatient, such complicated patients and urgent needs as far as if you're there for a stroke, like you're kind of ushered in, right?
Right.
And then when you have different sort of complications that put you in the hospital and you have a need for peritoneal dialysis as well, maybe some of the challenges in actually getting service.
Right.
Or maybe it's the challenge in finding somebody who knows how to actually do the procedure. But let's kind of go back a little bit. You started as an LVN. You became a registered nurse. You worked it's a great ladder, and that's a whole story in itself. But like, why nursing? Like, where were you born? Like, what inspired you to become this superhero again?
I was actually born in the Philippines.
Okay.
I came here about when I was 5 years old. Besides being, my whole family is a nurse. My mom's a nurse. Everybody in my family is a nurse pretty much. I've always had that desire to help people, and I think having that desire is one of the important steps that you need to have in order to do nursing. Nursing is tough. Not everybody has the heart. Like, not everybody would be able to do it unless you like what you do, especially during COVID, all these things that's coming up right now. Like, you have to have the passion for that.
Bless you
as
over
well.
there.
Nursing also gives you a lot of flexibility, especially at the hospital. We do like 3 12-hour shifts, and you're like off for like 4 days. So planning for vacation and all that, it's pretty much easier than doing the 5 days a week job.
Yeah.
So I love the flexibility, and that's one of the reasons why I stayed at the hospital setting too.
You mentioned nursing home. It's not the same there, right? Like a little bit different.
It depends.
The workflow
A lot
or
of
the scheduling?
nursing home pretty much does the 8-hour shifts where they work 5 days a week. But there's nursing homes also like rehab. A lot of them does 12-hour shifts too. So all depends.
Yeah. So I think when I was running a nursing home, we did 3 shifts of 8, and then everybody worked 4-2. Which made life kind of hell for a lot of people, right? You want to plan a vacation, or it's like very difficult.
The hospital schedule, it's different. Like you can space out your vacation days. Like you can work 3 days straight and then come back after like a week and do your remaining 3. So it's a lot of flexibility, just moving your schedule around.
Yeah. And we have a lot of friends that are passionate, like you said, about caring for people.
Right.
And you mentioned that if you're not passionate about that, probably nursing's not the right thing for you.
No.
It's hard work.
Yeah,
If you don't
it
have
is
a
hard
passion
work.
for it, then
Yeah.
the hard work
Especially
seems...
during COVID, you see a lot of these nurses moving careers or switching careers and all that just because of COVID.
Do you
But
feel
we
like
were,
that was
frontline.
was that like a eye opener for some people? Like, hey, I'm not in the right field.
Yeah, I
Really?
think it was. I know a few people that eventually switched careers after COVID.
So I've met a lot of nurses that during COVID kind of kept the nursing license and moved on to areas that weren't so,
Complicated.
maybe aesthetics, maybe writing, things like this. But you've met some that have just completely left the nursing field
Completely
altogether
left
as well.
the nursing field,
Wow,
yeah.
that's very interesting.
Yeah.
So I mean, nursing can be lucrative today, especially post-COVID, right?
Yeah, but there's a lot that you can do being a nurse. Like there's so many fields that, you know, like some wants pediatrics, some wants labor and delivery. There's like other fields that's open, and you can always switch. If you don't like where you're at in ICU, you can do L&D or you can do outpatient. And there's like so many things that you can do with that.
Yeah.
Which makes it much easier, just because you have a lot of options as well.
Yeah, I think that's a very cool part about nursing, but also about healthcare as a whole. Like there are entry point. I mean, you mentioned being an LVN, and that kind of maybe opened your eyes to other ways to leverage
Right.
that passion, right? CNAs also
Yeah.
maybe find like, hey, I want to be a nurse. I want to be a social
Yeah.
worker, a dietitian. So like, what, in your opinion, what's the best way for somebody who doesn't know? Like,
Honestly,
how do they dip their toe?
Honestly, I did nursing first because my mom's a nurse, and I wanted to be a flight attendant.
Oh, cool.
So my mom is in that stage where, well, if you're a nurse, you can get hired easily because you know what to do in case of emergency.
You can get
if you're
hired as
up
a
in the
flight
air.
attendant.
So I
Okay.
was like, okay, maybe I should just do that. So I was about
That's crazy.
17, I believe, or 17 when I did my LVN. And I was like, well, I don't know if I still want to do that route with the flight attendant thing. And then she goes, well, why won't you be an RN since you're already an LVN? So, you know, you have that family tricks
Yeah.
where it's like, well, you're already here, so might as well climb the ladder. I think, though, that's really important. So when you're a CNA, then you climb up the ladder as far as being an LVN. It makes a big difference as well if you're an LVN going to RN because you've studied these things before. So you're just advancing your career.
Yeah.
So I feel like it opens up your mind about like what you really want to do next and what you want to do with your career.
Yeah.
As far as being an RN.
So I gotta, inject my passion, which is hemodialysis, really. But
Okay.
I would say dialysis overall, renal replacement therapies. Ultimately, I'm very passionate about people getting transplants who have kidney failure. But my specialty's always been in hemodialysis.
Hemodialysis.
And I own a business. We train dialysis technicians. They're kind of the CNAs of the dialysis
Dialysis.
clinic. Maybe it's a little bit different because it's not like ADLs. It's a very complicated and routine
Yeah.
specialty, right?
Right.
But it is dipping the toe. I mean, it is kind of seeing like somebody who, in most cases, has chronic kidney disease secondary to something else, right? Type 2 diabetes, high blood pressure, other
Which
sort of glomerular
are all
diseases.
modifiable, right? But
Correct. So kind of you're leading me towards my
Right.
thoughts are, I've been in this deep thought since that guest that we had that was is a recovering alcoholic and sharing her story. And the choices that we make, and Paco and I talk about this all the time, it's like, you have the choice of choosing hard now or hard
Yes.
later, or choosing to think about your health now or think about your health later. Granted, there are things that put you in the hospital that you can't prevent.
Right, right.
But quite often in the world that I've lived in healthcare, and probably the majority of the people that I've seen sitting in dialysis chairs could have at some point said, let me think about my health, my weight that you
Yes.
pointed out to me earlier,
Yes.
that I'm over. Thank you.
You assumed. But, okay.
Well, it's because Paco's like beating me over the head like every day, like lose some weight, Morales.
Yeah.
She does the same to me.
It's more like, did you get your sleep? Oh, what time did you sleep again? Like,
Yeah.
those things.
Yeah.
Those things that you can actually do today to prevent complicated things that can happen in the future. Like,
Yeah.
everything is modifiable if you really act into it.
So when we talk about those preventable chronic
Yes.
conditions or those chronic conditions that you could have prevented, but also you can kind of put to a halt, right? You can stop
Right. You can stop. Yes,
by managing. I think that's a lifestyle.
it is.
In or out of it, right? It's a
Right.
lifestyle. And then we get sometimes we get all the way into it, like type 2 diabetes, and we end up with chronic kidney disease. And in the worst case, we end up with chronic kidney disease 5, and we need stuff like peritoneal dialysis or hemodialysis. And now I think about this pretty decent sized population that we have in the United States of people who are on different sort of dialysis therapies. Most of them get it in centers,
Okay.
dialysis facilities, right? I'm going to guess around 13% to 15%, somewhere in that range, get home dialysis, which would include peritoneal dialysis and home hemodialysis. Peritoneal dialysis being the bulk of that percentage that are doing it at home. And we kind of scratch our heads and say, why are more people not doing it at home if they can, if insurance will pay for it? Why wouldn't they want to do it out of the comfort of their home?
Well, you got to think about PD and versus hemo as well. With peritoneal dialysis, it's a lot of independence that's pretty much needed. And for my patients, a lot of my PD patients are pretty independent. They do it on their own. They go to work. They do manual exchanges, or they'll do cycler at night. So
Yep.
those are the convenience of it. And especially if you have that resource to help you out with all of that, I think that plays a big role too in like the home PD setting. Versus with hemo, you have to do it 3 to 4 times a week, which is if they're working, it's really hard. So like it's all about like the whole flexibility thing and how it would work for the person, right?
We've got a friend, he actually said hello to us, that JP, that he mentioned that he had been on both hemo and peritoneal. Chime in anytime, Justin, and tell me if I get anything wrong here, but he had been on hemo in center and chose peritoneal because of exactly that, the independence, the lifestyle that he wanted to live that was kind of free and doing things and up and about.
You can live your you can live your life like independently and just do it. But the thing is, you need to be consistent though. You can't skip or anything, otherwise you'd have further complications with that. So you have to really make sure that you have control over that as well.
I think he told us that story as well, as kind of like challenging and how he felt when he, maybe delayed or missed the treatment, that he didn't feel so good. And it's kind of lessons learned, right?
Right.
But, thinking about that, like you said, the independent, that's kind of what we want, right? It's in life, is we want independence. So when we say it, like even 13 to 15% at home, it could be much higher than that. It could be much higher than that. So, what are the challenges in getting people to, one, be presented with, and then adopt, entertain even the idea of home dialysis that you've seen?
I think it's more of education too. A lot of our patients, they need to have options. They need to sit down with a nephrologist, a specialist, to see what would work for them. Pretty much educate the difference between hemo, PD, what your lifestyle is, if you're working full time or whatsoever. If PD would work for you instead. It's basically learning the advantage and disadvantage of pretty much both. Like I said, with PD, it's more of independence. We have patients working full time and doing PDs at home or when they get home, those things. So I think primarily education too. See what works out for them and what would work better, pretty much.
I want to dive into that, like what works out for them. So, Paco's a young guy, just turned 25, right? And then we got, another gentleman over here who's 82, but he's a Spanish speaker. And then we've got somebody over here who's, been coddled by their parents, is 40 years old, but never had any responsibility of their own, had the spoon put in their mouth their whole life. How important is it to, when we educate, like meeting them where they're at
Yeah.
and customizing it, personalizing it, how important is that towards
It's very
adoption?
important. Like you said, you have Spanish speaking, right? Like in the hospitals, we're required to provide those language, pretty much language barriers are really like to learn. It's really important for you to make sure that your patient understands and you provide them in the right language that they can understand.
So translation services. What do you guys use in the hospitals? Like the little roll-arounds?
We have like a video.
Okay.
It has like multiple languages. You just click on the language that you want, and pretty much it's like a video
So it's a
call.
teleconnect with a translator. Okay.
Yeah, but it's like language barriers, right? It's like if you admit or discharge a patient, when you educate them with something, and if I speak English and they're like full Spanish, of course you would need to make sure you have the proper interpreter to say those discharge paperworks, because it's a lot of education too. So if you don't address what the barrier is, you're just going to see them get readmitted again because they didn't understand what they need to do to avoid the things that the reason why they're in the hospital in the first place, like those things.
So you're not just presenting slides to people when you're doing this, you're like diving into their life.
Because you have to also, there's a lot of different patients, so you need to address how they learn. Like, are they more like hands-on, or are they, like vision or those things? Like you have to address those and what would work. And return demonstration too is really important, especially for these PD patients. Like if we have a new PD patient that's just about to come home, education is really important, and having them to return demonstration is another thing to make sure that they understand what they have to do.
Yeah, agreed. I've got a friend, the Gilchrist family, but Christina Gilchrist, she's actually legally blind and did peritoneal dialysis on her own.
Oh, wow.
Yeah, it's crazy, right? She's now does home hemo with the help of her care partner, Michael, and they really share a lot of content on YouTube, on Instagram, but they show like how they set it up with the equipment they use is the next stage equipment. Are you familiar with that? It's a small portable hemodialysis machine that people actually can take to the beach, even put on a generator. Like it's literally that portable.
We don't really see a lot of that at the hospitals because we have our own hemodialysis nurse that comes in.
So the hemodialysis is the big machines, the big legacy machines with the water system.
Hasn't changed yet.
Yeah, I mean, there's some exciting stuff, and I'll share more with you maybe after the cast. There are new devices that are on the market, and there are some that have been around that are smaller, like the one I mentioned that's very portable. There are others that have like the water system in them. Different flow rates, different benefits with flow rates, right? So back to the customization, because I think I'm Latino, right? Like if I get myself in problems with blood pressure and diabetes, it's probably my wife's fault actually, because she's Filipina, but she's the one who cooks all that salty stuff, right? But it's very easy to live a life to fall into whatever.
Right.
Alcoholism, addictions, chronic illnesses, which maybe those are chronic illnesses, right?
Yes.
So it's very easy to get there my way. Like I chose it. I'm thinking of times where, my parents, hey, don't do that. Like I'm an adult.
Right.
It's my way, right? So customizing, do you see that? Like, is it happening? Is it being personalized to the level that people need?
Pretty much, yeah. Like I see a lot of patients at the hospital where they had a TIA, for example. I work at a stroke unit, so we see a lot of TIAs. Yeah. And it's basically like, well, what have you been doing? Oh, well, my doctor told me that I have blood pressure. I'm like, were you taking your medicine? And they're like, no, not really. I don't, because like sometimes I check it, it's like normal. So they assume that, they're fine, but the change it's going to happen when something happens to them, right? So now they have a TIA. Luckily, nothing was damaged that led to a stroke. But at the same time, it's like, well, this won't happen if you did this,
right? That
type of thing. So, if you have high blood pressure, it's modifiable. Like you said, living an active lifestyle, pretty much, your diet, your active, exercising, getting your sleep, and just basically being compliant, it really makes a difference.
Can I ask this is, you don't have to answer if you don't want to. Let's think about the United States, like top athletes.
Okay.
Who are they?
Top athletes. Like, who are we talking about? Like LeBron James?
Okay, well, you just started with that. So
Kobe?
LeBron,
Kobe
they're both black guys, right? Why is it that they're so disproportionately affected with chronic kidney disease and high blood pressure and diabetes? Like, we're thinking of the upper echelon of athletes, and first thing that came to your mind was a couple of guys that are in the NBA that happen to be black. I'm not saying they're affected with this, but what I'm saying is, when we say that healthcare is being specialized enough, I want to know, why are black and brown people, are they more prone, or are they just more incidental? I'll ask you that question.
Like, in our studies, they would say that there's certain, like, ethnicities, for example, that are more prone to specific diseases, right? I would say factors too that would lead them into developing it. I mean, like, what are they doing as far as, are they not resting well? Are they stressed out? Of course, they have like a lot of things going on too with their lifestyle. I'm not sure.
No, I think, the, what do you call it, the socio-determinants, right?
Right.
That they're stacked up against the ethnic population, multifamily households, often working multiple jobs.
Yes.
When you have those scenarios, you don't sleep well, right?
Yeah, I was like that.
the-
I had 2 jobs and stuff. So.
Not eating right. What was it? Fast food on both ways, or what?
Pretty
Or just
much
not eating.
not getting enough rest.
Yeah.
So you just get burned out easily. So
Yeah.
that's another thing, burned out.
Yep. So, okay, there are factors that are probably environmental, cultural, sometimes what we like to eat, our ethic, our attitude towards doctors in some
Right.
cases, right? Our access.
Access as far as insurance.
Yeah.
Yeah, definitely.
Yeah.
That plays a barrier.
Yeah. So odds are stacked up against certain demographics to get into chronic illness. So there are more black and brown and Native Americans that are suffering from chronic kidney disease than let's say the white or Asian populations. But when you look at the home dialysis utilization, they're on the lowest. So why is that, do you think?
I think it's more of like compliance. Like, are they in denial, and are they like in denial if they're really facing some issues with their health? That type of thing, I would say. If insurance is really important for that too.
Yeah.
I mean, how are you going to be able to take care of yourself if you don't have those as well?
So we have a question for you. Do you need extra education to be in a unit dealing with PD patients?
The minimum requirement for us is having an associate degree, at least. So that's an RN, ASN, ADN. Our unit basically does not, well, our unit is specializing in stroke and PD. Not all the units does PDs as well. So that's the thing. So basically, when you get hired for our unit, part of your requirements, you'll be trained to do manual PDs.
Tell us about that, the training. So you were trained by the hospital
Yes.
in the unit that you're working at to do PD exchanges
Yes.
for that unit?
For that unit.
Okay. And what was that like? The hospital did it? The manufacturer did it?
We have both,
Okay.
basically. Yeah. I've worked at multiple hospitals where we've never done PD. And when I moved to Kaiser, I was surprised that, we actually have PD. I was like, why do we have to do that? Like, oh, that's part of your unit's job. And it's like, well, that's an extra job. But, it's rewarding. Like,
Yeah.
to be able to know how to do it, and the rest of your coworkers in other units are not able to, it's amazing. Like,
So did you understand, like, before you were doing it, what it was and, like, why it was so important?
So I was more I had more ideas with hemodialysis. It's what I've really seen, like working at different hospitals. It's always about hemo. We've never had PDs. And if we did, we would have to call it like an outpatient PD nurse to come by.
Yeah.
So that's one thing. But at Kaiser, I was surprised that there was a lot of PD cases as well.
So
it's fun. It's fun doing it.
It's fun doing it.
Once you learn how to do it.
Well, I agree with you. I mean, I feel so. Obviously, I have a passion for dialysis as a whole because it's not a spot fix, right? It's not patching a tire. It's like life sustaining, right? And quite often I get in these conversations with techs and nurses that are doing dialysis, and they're like, lifesavers, right? And I don't see it that way. I see it as, life sustainers, helping people to live.
Right.
Like, I don't feel like the therapy itself is, in most of the cases, saving the patient's life today. It's keeping them within that homeostasis so that they can live. And, hopefully it's doing enough to actually give them some sort of quality of life, not just putting a needle in or tapping into a catheter, doing exchanges and keeping them breathing and heart beating, right?
You have to also address their psychological issues too, because there are some patients who just started PD, for example, and of course it's something new to them. And like you just basically teach them how to do this and that, but to have like that psychological thing where I'm starting something new to myself, that plays a big role in compliance too.
So I'm curious, compliance or self-management?
Pretty much both.
Which one do you, if I'm your patient, which one do you use?
I hope you would comply with what we do, right? Like what we would recommend for you, pretty much. And you have to be self-motivated as well.
So I talk with a lot of dialysis social worker, right? And we try and learn every day. What's the patient experience, right? We used to say end-stage renal disease to people. I don't know if you still mention this in the hospital. But we stopped saying it, right? Because it's it's end stage, right?
It's like acute renal failure. We say acute kidney injury now,
right? Exactly. And that's like a perception, right? And I'll just shout her out, Dory Chattel, who she's been such a big contributor to the nephrology community and putting out education, especially for techs, right? And it's she publishes this book called The Core Curriculum for Dialysis Technicians.
Oh, wow.
She always corrects us and says, let's never call somebody non-compliant. Let's always talk about self-management. And I'm curious to know your lens on this. If you give me advice on how to care for myself in between exchanges and how to do exchanges and how to manage my diet and what medications to take, things like this, and I don't do it, who do you look at, you or me? Sorry, it's a trick question.
No, I would look at who discharged you, for example. Because you need to know the risk and benefits of why we're doing this, the further complications that can occur if you don't do it, those things as well.
Yeah.
But as far as you actually complying with what we're recommending, I think that's really important.
Yeah, I agree. I think it's important. And I guess what I'm trying to impose is maybe I take things too seriously sometimes, but I always think if a student doesn't perform the way that I want them to perform or that I know they can perform, I always look at myself. I'm going
is it you?
How do I got to change my lesson? You know what I mean? And going back to personalization, do you feel like we're failing patients or they're failing themselves more? Who do you think's got the heavier load there?
Honestly, I feel like nowadays, because of the nursing shortage and all that, I feel like the time that we have for patient education, I think that's really lacking.
I agree, 100%.
So
that's one of the biggest hits we've taken.
One of the biggest thing that we've had patients that's they didn't tell me that I have to do this and that, which they should have told you, but it's well, what was the reason behind it? There's always a reason why.
Or maybe they did and they didn't ask for the return or the validation that it was learned, right? So I agree with you on like return demonstration, like making sure that
especially
what
with
I've
PD,
communicated. Yeah, you get
like
it. Yeah.
everything that you have to do is like make sure your catheter doesn't touch this or that, like to prevent infection.
Yeah.
That's like a big thing for them also. So that's like another. But how good was the education during that time? That's the question. Or if did they actually take their time teaching you or educating you, or did they just say, here's your paperwork, this is what you have to do?
Again, you're segueing into my thought here. So what's the difference between education and communication?
Paco was supposed to also talk. I don't know what happened.
Paco, since you're oohing and ahhing.
Yeah.
No, I'm just amazed at the conversation. So
So the difference between educating and communicating.
So actually, you would have to do both as a nurse, right? You have to educate, meaning you need to have, of course, you're not going to teach something that you're not familiar with, right? Like if I was a new grad versus an experienced nurse trying to teach you how to do this PD and how to prevent an infection, I mean, you would have to reach out to a much more experienced nurse to provide the proper education, right? And you would have to communicate that well with the patients as far as addressing whatever barriers that they have. So that's one thing as well. As far as you have to have the right education. You're not going to teach like a diabetic patient if you don't know how to use that glucometer and you're going to discharge. If you don't know how to use it, are you going to be able to teach that?
No, I agree with you. I think technically you got to know.
You got to know what you got to know
the nuts and bolts of it, right?
Exactly.
But then we all know a nurse that is like the best nurse but can't teach shit. I'm sorry. Like there are nurses out there that they're like the best. Like I want to work with them, but don't have them teach me or teach a new person or teach a patient in some cases, right? And not just nurses, but educators as a whole. There's like people out there that have no business teaching. So, when you talk about barriers, I feel like that's one of the secret ingredients.
Right.
It's like if my 10-year-old son's in school, and which he is, by the way, we're not breaking the law, and he's learning from these teachers a bunch of stuff that he can't apply to his life, then it's useless.
Right.
Right? When we're going out there and learning these skills that we can't actually do. Paco, I know, teaches CPR.
Yes.
Like how many people take CPR and don't know shit about what to do when it actually happens, right? Not from Paco, by the way, because I know he like makes sure that they got it. So again, I think there are a lot of people out there that technically know how to do the jobs. They might be model employees, but they have no business teaching new people, patients, et cetera. When you talk about the nursing shortage and then the lack of these educators, I feel like it's crippling to the healthcare system as a whole.
Right.
A lot of things are going home. Like we had a guest on here recently. She works in transitional care in the hospital, same group. And everything is going home, including dialysis, right? So I feel like knowing the barriers, we often disqualify people from that type of care, whether it be peritoneal, especially hemo. I know there's a lot of patients, they say, oh, they're not a good candidate. The team will say they're not a good candidate for home hemo, right? Have you had any experience with maybe teams that are overlooking patients' abilities to take back? And maybe it's in some cases because we know that we cannot communicate in a way that they can apply it practically and be successful at it.
I don't really have a lot of experience with the home stuff because I work as an inpatient nurse. Yeah. So we normally see a lot of these patients that's getting admitted because they need hemo or they need peritoneal dialysis in the hospital. Yeah. The only experience that we'll have there is to make sure that when they do get discharged, they have everything that they need at home, whether a hemodialysis has already been arranged as far as the scheduling, or they have a peritoneal dialysis like all their equipments are already delivered
Back
before
at
they,
home.
back at home.
Yeah.
Or there's a PD nurse to make sure they have home health visits with those things to make sure that they're really complying or doing that or knowledgeable about what they need to do. It's pretty much those are my experience. So we get the type of patients that we send you home for a PD, for example, and you're supposed to do an exchange, a manual exchange, like 4 times a day, and you don't do it, or you only did it once a day. Then you have all these symptoms like retention and swelling and all those things, short of breath, and then that's when they come into the hospital. Pretty much those are my experience. I have not really I don't have experience with like the home setting.
Well, I think you do. I mean, when you think about who's coming into the hospital, right? You're seeing these home patients,
home health,
right? They're PD patients, right?
Yes.
That come in. You're working on the stroke unit on the other side, but do you see a lot of hemo patients that are chronic patients coming in for treatments in the hospital as well?
If they miss their days, for example, when they have to come in, like MWF, and they miss their schedule, it messes a lot in their system as well.
Absolutely.
So that's one of the reasons why they go in the hospital. And sometimes you'll see them getting like an extra dialysis day just to fix whatever problems they have. So
what about infections with dialysis patients being admitted to the hospital? What do you see more?
We see more with PD.
More infections with PD?
Peritonitis.
With peritonitis, okay.
We see a lot of that. And that's where the education comes from, right?
Yeah.
Like you have to make sure like your cap is brand new. You have to like teach them that, you know, that can't touch any surface, make sure like those things.
Yeah,
like,
it's a lot of discipline involved.
It's a lot. And that's where the exchange comes in, because you have to treat them now with antibiotics. And sometimes we have to place it in the PD solution too.
Yeah. So talking about rest.
Rest.
You know, we got this dialysis schedule, and you mentioned a lot of the 12-day schedules, and you said it's flexible because you can work 3 days a week, and then you can do what you want on the other days. But why is it? And I'm gonna call it out, but like most Filipinos I know, they just go ahead and take 2. They work Monday, Wednesday, Friday, and Tuesday, Thursday, Saturday.
That all depends. Like we have a block schedule at Kaiser, so. Like my schedule would be like Monday, Tuesday, Saturday, Sunday, Wednesday, Thursday, that type of thing. But I have the option to switch that out. So I can ask my coworker, like, can you work this day and I'll work this day? Then I would have like 5 days off straight.
Got you.
Know, those
all right.
things.
Yeah.
But it's tiring.
Yeah.
12 hours
I'll
is
tell
no
you,
joke.
dialysis.
It's not even 12 hours.
Most
like
people
14.
are working both of those shifts. And even like techs, you go into a dialysis facility parking lot and they're driving nice cars, like probably as nice as the nurses because they're doubling up on their days, getting overtime every day, which is great. But do you feel like the sacrifice of sleep and rest, does it have an impact? We already said it has an impact on health.
It does.
Does it have an impact on our
like
performance?
Thinking? Of course, yeah. Definitely.
Any experience with that? You burned yourself out and like.
Can
you tell
us what happened? I've done like a 23-hour shift one time, and they couldn't go over because I guess it's against the law or something if you're a nurse.
They're like, go to sleep
in general.
Go to sleep in the lobby or what?
So I did a 23-hour shift, and I drove home. Literally, the only thing that was functioning was red light, yellow light, green light.
So it was just
I was a
subconscious,
zombie. I was a zombie,
Yeah.
And it was terrible.
Was that in nursing home or?
I had a migraine the next day. It was hospital.
Hospital.
Yeah. And it was like during the holidays, so like Christmas where everyone's calling in sick.
Yeah. Well, that's the norm. That's the norm.
Definitely performance. Like you can't go to work where, you know, you had 2 hours of sleep. Like if you don't take care of yourself, how are you going to take care of your patients?
Yeah.
You know?
On that, you kind of mentioned, it sounds like you have a very close relationship with your mother. Being that she kind of said, hey, be a nurse, and, you know, why don't you go be the RN?
She wanted me to be a nurse just because everyone's a nurse in my family. Like my cousins, my sister, everyone's a nurse. And she said it's basically money, you know, you'll be stable.
Yeah.
It's stability pretty much. And she has CKD, by the way. So she's dealing with that. Pretty much wanted me to be a nurse because she wanted me to be stable. So that's how I mean, she was stable, so that's why she's like, okay, well, you have a lot of options.
Lucky that
in
you
nursing.
actually liked it. I mean,
I
which
did.
is great.
Yeah.
That environment for you led you to this life.
Pretty much, yes.
Yeah. So what about our patients and them being walked into that life? And then, I mean, if you were there, like, mom would be there, I'm assuming, with you?
Yeah.
Yeah. Going through this with you, helping you with decisions, maybe, kind of guiding you on next what to do or how to think about life and things like this.
Yeah, she can do that.
I mean, I'll just tell you, my wife's Filipino and her mother, like, I love her, but if she says something, my wife's she's gonna do it. If there was a question about health and she said, "Oh, take this pill," my wife's gonna do it.
Yeah.
So how important is it with the patients that you work with, I guess on discharge, that mom or spouse or brother or partner in crime is also part of that
Part of the
education,
team.
communication,
I think it's really important.
inclusion. Really important.
Yeah.
Yeah.
Yeah. Just
So-
because you have all those people that would support you as well
Yeah.
with that one. And would remind you basically what the consequences are if you don't do what you need to do, those things.
Do you see a difference when people come in and they have a male partner and a female partner and that support? Just
No, not
curious.
really.
You feel like it's kind of equally
I feel like
offered?
so far with my experience, it's been equal.
What about like the demographic of your patient? Do you see certain demographics being more prone to help family member and others who don't come in and visit them?
So I would say Hispanics and Filipino patients, especially, they're very hands-on with their family members. Whoever's admitted at the hospital, they're very hands-on. You'll see like a Hispanic patient that I would have, and they would have like 7, 8 family members in the room to just visit. And then, of course, we can't, like, that's another problem that we have to deal with too, because it's like you have to discuss one thing with that person and then another one comes in and you
Yeah.
have to like communicate with each other. But to have that support, I think that's really a blessing for the patient as well.
Yeah, agreed. I think, so I'll quote Lori Hartwell. You definitely want to look this person up. For transplants, every modality of dialysis, I want to say probably 50 years of kidney failure leading a nonprofit. But she says that chronic illness is too difficult to face alone, and too difficult to face without hope.
Yeah.
So I always say that, like, the people that love us, part of their job is just to remind us, like, why? Like, why are you going to do dialysis? Why are you going to take your medicine? Why are you going to, back to this conversation we've had a while ago, Paco, like, see something, say something. In certain families, that's really important, right? Like, it's not just like we're eating a donut or drinking a Coke, but, you know, we can see family members who are doing the worst things than that.
You hear
Yeah.
that a
That'd be
lot.
rude.
Like,
Yeah.
I told you so. Like,
Yeah.
I told you you need
But
to
you
do
can't say
this. I
that,
told
right?
you not
You
to
do hear that. You do hear that.
With family members, yeah.
Oh,
We do.
that's mean.
Yeah.
But, you know, that kind of takes me back to communication. And I'm just going to get, like, personal here, right? Like, I've been thinking about, like, everything meshes for me, like health, wellness, sickness, you know, conversations about addictions, problems in families. They all mesh to me, like, with the same prevailing themes. And it's like communication, right? So
Right.
for me, something very real is I have 4 kids, and I just mentioned it recently, like, I'm starting to figure life out. Like, oh, that you were effing up, Morales. Like, almost all of your life, you were just doing the wrong shit, right? And still have a lot to work on. But to watch kids make the same decisions when you know that it's effed you up is super difficult. So what do I find myself doing all the time? Like, just
Which they don't want to hear.
bitching,
most of the
bitching,
time,
right? Yeah, they don't want to hear that,
Yeah,
right?
they don't want to hear that.
So, like, I'm trying to get myself together and go, like, how do I communicate with my kids
Right.
in a way that I'm being heard? I said this last week.
Yeah,
Like-
and you're not
Yeah.
coming out as a nag.
Yeah. Yeah, because I have a genuine concerns, right?
Right.
But and it comes from experience. But all that comes out from my mouth is like, like I would hate myself, or I would hate me if I were hearing that all the time. I would hate a nurse who's telling me that all the time too.
Yeah,
right?
yeah. Honestly, with my kids, I tell them like, hey, I had this patient today. He's 18, and like his X-ray was so messed up. Like his chest was this and that. And then they're like, what did they do, Mom? Like vaping since they were like 13.
Yeah.
And then I would show them like pictures. Like this is what happens if
Scare
you do
tactics.
that.
Yeah.
And I'm like, oh my God, like those things.
Who's vaping?
Not me.
Is it you?
It's like, who's vaping?
So those little things, or like I would tell them things, and my daughter's interested in nursing too. So like when I say stories like, oh, I had a patient like she was drinking a lot. Now this is what happened to her liver. Da 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 da. And she was like, oh wow, really, Mom? Like those things. So
Yeah.
it's like experiences. Like
It's very similar to how you would work with one of your patients or the people that you're helping, right? It's like,
right.
this is important because this is what I don't want to see happen
Right.
to you. I can remember, people that I was helping with dialysis that didn't want to take certain medications and then doing similar things.
'Cause
Like,
it
hey,
gets a
here's the
lot.
kind of things that, it is. Like, it's a ton of
it's a ton of
medications, right?
I have a
Medication.
question for both of you. Do you guys get frustrated? Like, instead of saying, I told you so to your patients, both of you, like you, Mike, when you were a dialysis tech, and you, Jay, whenever you see a patient come back, like deteriorated, how do you show frustration, or do you guys even feel empathetic toward them?
I do. I basically say like I like try to figure out what went wrong and how you led to this route, pretty much. Like, did you not have enough help? What do you need help with? What can we do after discharge for you to feel better? Like those little things. Like say if he had a wife that usually gives him his medications, for example, and the wife wasn't around.
Yep.
Those can lead them to like not take those meds and have face those consequences, right? So those things, just trying to figure out what went wrong at home.
Yeah, I would agree with that. It's like, I tend to think of, so I've always worked in chronic hemodialysis, right? As far as clinical. And I tend to think of myself as like, I'm not 100% sure, but I think like Kobe Bryant. Like, if he doesn't pass the ball to the right person, then the play doesn't, right? He's the one who did that, right? Like, what do they call that guy? Point guard?
Point guard.
Point guard,
Right?
yeah.
That's what he did, right? Okay, so he's the playmaker, right?
Right.
And I kind of think like, well, dialysis techs and dialysis are playmakers. It's like, hey, something's different today. Nurse Jaye, can you come check out Morales? Like, I normally hear his bruit all the way up to his shoulder. Today it's only to his elbow. Can you check it out?
Yeah.
Can you assess it, right? So I made the play happen. If I don't tell you anything, the play doesn't happen, right? And when it comes to like education, I feel the same way as well. It's like the nurses and the social workers and the dietitians have very little time with the patient in that setting. The technicians have 4 hours in most cases to sit with these people Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. So if you come and educate the patient, I want to be there with you and hear what you're saying so I can reinforce.
Right.
And
Here's my, sorry.
It's like a team.
yeah,
Question to Jay. Do you give credence and importance to whatever the dialysis technician tells you guys if it goes up the chain of command in that manner?
Yeah, we do. And that's really important to address too. Because, you have...
Because there are nurses who have egos. Sorry.
Exactly.
Yeah.
Right?
yeah.
And then
But there are techs too.
sometimes we have techs, they're really good at doing a before and after weights, for example. I would say they're very good because a lot of our nurses, sometimes they miss a morning weight, right?
Yeah.
Which is really important with dialysis to make sure, they're not gaining.
Yep.
That's like a teamwork is really important with that setting.
Yeah. Well, I mean, we talked about the nursing shortage. Today, it's even more important.
worse,
like, you have to extend your license now, right? As a nurse, like, you got to extend your license to the CNAs in the hospital, to the techs in the dialysis centers. Because you can't do it all. The nurses cannot do it all, especially in those chronic
Yeah,
hemodialysis
and I think
centers.
they've been doing it all because we lack resources pretty
Yeah.
much.
Yeah.
That's one challenge in healthcare too.
Yep. So, I had a question. Who's this? Richard Vanderplas, our buddy. In many cases, patients are told what they shouldn't do without an explanation of the why. 100% agreed. And it kind of goes back to my
Yes.
thing of like, I'm just going to say it to you. I don't like the word compliance.
You don't like the word
No,
compliance.
just because I feel like I wouldn't respond to that. Like, I don't need to comply with you. This is my life. It's personal. Tell me how to manage this thing while living my life. So it becomes like a self-management thing, right? It's like, it's up to you. Hey, you want?
up to you.
Do you guys see this guy who he's got this hook in his I don't know if it's a TED talk or what, but he takes out a cigarette and he's on stage and he takes it out. He's about to smoke it and he goes like, everybody's like, whoa, right? And he's like, what? If I was going to eat a candy bar, none of you would. He made up these statistics that basically, smoking doesn't kill that many people, and eating candy bars much better. He said, I just made this up, right? But he sunk into that hook, and it was like, you can make anybody believe anything
Yeah.
for the most part.
Yeah.
But again, like meshing it into my life, I think is super important. And to Richard's point, like, why shouldn't I do it? Like you do with your kids, I think is super important. Then it's like up to you, right? Hey, you want to smoke? Do you know it does?
It does this and
This?
that. Yeah. I tell them that.
For your kids right now, you can tell
Yeah.
them no, but eventually they become, I don't know if they're adults already.
Yeah, no, my daughter is 16 and my son is 12.
So one day they can light a cigarette if they want to, or
yeah.
vape, or whatever
So-
else they want to, right?
Yeah.
They have to self-manage. They don't have to comply with
It's
you,
going
right?
to be basically like a decision that they have to make on their own.
Yeah.
I mean, they're not going to be always surrounded with like people who doesn't smoke, people who doesn't drink or do
That's right.
drugs,
Yeah.
So
Yeah.
I think the final decision it's going to be,
Especially if they go to college.
Yeah.
Right?
You can
That's the
relate
scary part. Oh my God.
Some people, that's why they go to college, right? Is they're going to find all the,
the partying
The
and
stuff
stuff
that-
like that.
I mean, hey, I liked it all.
I didn't do any of that during college.
You're
High school.
Janelle. We went to the same high school, so.
Oh my God, they're
she
throwing
knows.
each other under the bus now.
No comment. Let's go back to this conversation.
So let me ask this. Discharging patients that are going to take care of themselves, whatever fashion, home. Let's talk about the stroke, the stroke unit now, right? Patient gets discharged, let's say home. Now it becomes self-manage,
Yes.
right? You do this, and this, right? And we can go find plenty of literature to say that more frequent touch points for patient leads to better outcomes.
Right.
So what's the plan for like the stroke units to make sure that those touch points are happening when the patient's at home?
So with our stroke patients, we always have like a discharge plan as far as, I would say, like steps that you need to discuss with your patients that's required for education. So it's basically like for us, if we miss anything on that paper, we get dinged for it as a nurse. So we have to make sure that everything on that paper, it's like a discharge paperwork, everything that you need to do there has been addressed pretty much, as far as the swallow eval, as far as their medications, what they need to take, what they need to do, and all those things. It's like basically a checklist that you have to go over with the patients, and you have to check all that before they even get discharged. And they have surveys, so it's gonna say, did you understand what your discharge education is? Did your nurse or your doctor explain this? Do you have any other questions? Because if they do, then we have to address it before they go home.
What sort of technologies are you seeing that are connecting physicians when patients are discharged? Remote patient monitoring, devices?
We have like a Get Well network system where, like, if I'm providing you a stroke education, we make them watch videos. So we're with the patient sometimes if they need to watch those videos. It basically teaches them like why this happened, what you should do, and at the end of that, education part, it has questions for the patients to answer.
Okay.
So
It's like a retention,
it's kind of
comprehension
basically
type
what
of thing.
like it tells us like, okay, what did you learn, and like what other questions you have for us and all that. But prior to that, one of our our requirement is to make sure that the patient has all their questions and concerns addressed before discharge. So that's an important factor before they go home.
Are any of your patients being discharged with those orders, like remote patient monitoring platforms or anything like that?
I mean, they what's good with Kaiser is, when you discharge them and there's like multiple referrals, it's pretty quick. Like if they need to get referred to like cardiology for like a Holter monitor, like those things, those are pretty quick. But it's also your responsibility to make sure like all those referrals are put in already.
Right.
And whatever home health needs that they need has been addressed, because it's a whole different department. Like you have to go through case management needs to arrange whatever home health needs they have or deliver whatever medical equipments they need, those things too.
So what's your experience with people being deployed home with Holter monitors, with blood pressure cuffs, glucometers, different sort of things, and the challenges in that, in actually being able to use it?
Blood pressure monitoring, for example, well, it's all automated now. We don't teach the manual stuff on
Pumping.
patients anymore because I don't know, they still sell that nowadays.
Yeah.
Everything is
Funny
so
conversation.
automated, so that like I said, you have to make sure that, I mean, you can't just go home with hypertension diagnosis without a blood pressure machine, right? So part of your education would be you need to buy a blood pressure cuff, and you know how you need to use it, because it's important for you to take your blood pressure before you take any medication. So that type of thing. But I think everything is easily accessible now as far as what you need at home.
I think it's easily accessible, but I mean, even with the blood pressure, so I have a little bit of experience in remote patient monitoring, and we built a company a few years back, built a platform so that your blood pressure would be captured in the cloud and then sent to the physician.
Sent to the physician.
You could build the CPT codes, things like this. And it seems like, oh, wow, great. New revenue line, and I get to keep track of my patients more frequently, right? Well, who needs this? Like, most of the patients that were being referred, they have 2 comorbidities, and their age was up there. So like, well, I need to have an app on my phone and like this sort of stuff. There were challenges.
Not every patient can do that though.
Right.
Like if you're in the older side, you're not going to expect your 90-year-old patient to basically be, hey, just send everything digital, just do your blood pressure, and then we'll see it in our system. It's it doesn't work for everybody, honestly.
Agreed. So do we disqualify like that, or do we like look at it as a barrier that has to be overcome? Do we look at the 75-year-old who has like a old flip Android and go like, hey, you need an app, and like, oh, I'll do it, and then walk them through that? Or do we just say, no,
I mean,
you're 75?
We can't. You can. There's a lot of 75-year-old patients out there that's really independent. But I mean, to get as much help as they can is really important too, to basically get to what they need to do. So if you're 75 and I have like a really supportive husband that would like teach me or guide me to do that, that's another thing but if you're like alone and solo.
So back to the family, the network is a big help, right?
It's a big help. Whatever your support system is really important, which not everybody has. So like, I feel like everything is so advanced nowadays, but you have to think about like older people too, that's not used to like these electronics or these new systems that's coming by, So
let's kind of round out the cast for tonight, but I want to dive down that road. If I don't have a support system, but let's say the organization that you work for says, hey, we'll send somebody to you.
Right.
That again, that's like, wow, great. That's great.
Yeah.
So I want to ask you, as a registered nurse, are there places you wouldn't go? So would you go to like Compton in the neighborhood?
Why not?
Okay, that's great. So we know who to send to Compton for the. But you understand my question is, do you feel like it's a Do you feel like that's a barrier on our side, on the professional side? Do you think all nurses are? Is there a safety issue with going into patients' homes
Yeah, definitely.
and neighborhoods,
Even
and
in
parking
hospitals,
lots and stuff like this?
nurses deal with so many abuse too.
Yeah.
So,
Yeah.
I mean, if it happens in the hospital already, what more if they're at home?
Yeah, yeah.
But
Any thoughts on how to address that side of it, safety for deploying?
I mean, I
we're
think
going that
every
way.
nurse should speak up if they're uncomfortable going to a specific place.
Mm-hmm.
And I think the company should be responsible to provide assistance if the nurses do need it. I've encountered a lot of nurses that complains to me. But it's like,
But
well,
you're not
did you
HR.
tell management?
You're the
They're like,
empath.
no.
You're the empath, huh?
Yeah, pretty much. But I mean, we have a lot of new nurses here too that gets like petitioned and then
Yeah.
they get these jobs. So I feel like they're scared to speak up just because they're like starting.
They're on
So I think
contract and-
they're
yeah.
in contract,
Yeah.
and this is like their stepping stone to like, to improve themselves and provide for their family. So I think that's one of the things where they have to suck up everything, like all the abuse that they have to take, and they would just have to suck it up because they have to do it. But
Yeah.
I don't think there's anything wrong with speaking up.
Well, that's a great discussion point. When you talk about a culture of safety and quality, right? That there's two words that like I knew as a tech that I could get my nurse's attention or a doctor's attention, even as a tech, right? And I shouldn't say even as, but at a certain point in my life, I felt
Yeah.
like even as, right? Never, I never would. I shouldn't even have said that because the techs are like a pivotal role in the dialysis facility, right? But that culture of quality and safety, yeah, part of that is that no retaliation. If people feel like there is a retaliation, if there's nepotism, which is actually pretty damn common in healthcare, right? Like, let me go talk to the DON about so-and-so's performance. Well, that's the DON's cousin, or that's the
Yeah.
DON's sister or sister-in-law or best friend or, A-team, right? This happens a lot in healthcare, right? We pull our teams and we run with them. I know
What do
that.
they say? It's who you know, not what you know.
Well, I always say that it's who knows you, like
Yeah.
not who you know, like who knows you and what do they know about you, right? Like I'm gonna take you everywhere with me if I know that all the things that you just told me are true about the way you care about patients and the way that you deliver education and communicate. I'm gonna take you everywhere with me because I know that consistently that's how you're going to perform, right?
Right.
So if I know that about you, that's more powerful than you knowing me, right? If I'm in that, if I'm in that hiring position,
Yeah.
it's like, do I know you? So agreed there.
I am more passionate now because I basically know what I want to do. You know what I mean?
What,
And
what,
like
what do
I
you want to
said,
do?
during my master's in science and nursing specializes in nursing education. So I've always been like the preceptor and teaching new grads, nursing students are always like assigned to me pretty much. I've always wanted to stick with the education system. But honestly, there's barriers with that too, as far as the pay. We know teachers don't really get paid more with those settings. So
Yep.
that plays a role too versus I like inpatient nursing. That's what I want to do. Do I see myself doing that forever? I actually don't. But it's more physical for me, which we won't talk about. Pretty much sticking into the education side is what I see in the future. The reason why I did MSN in education is because I know in the future, in near retirement or so, I still want to go into teaching.
So what's rewarding about teaching?
I'll have nursing students who passes their NCLEX and, they go back and text and calls you and, thank you. Like, it's really rewarding. It's like you made a difference, with nursing students or new nurses or patients, that part where you really make a big difference. It's real.
So I don't know if you caught my background. I started dialysis
Yes.
because my
Your
uncle was a
uncle,
patient, and it was like a natural thing, and I ended up liking it, and then got into education, opened a business, done a lot of things in operations, right? But I just had this same conversation with a physician friend of mine today. And it was like, how are things, Morales? Are you happy, right? And, no.
You're not happy.
No.
Why?
No, because I feel like I have something to do, right? Like I feel, and I've always felt that way, and I'm never satisfied. Like I love taking care of people, and when I was working in the clinics, I like to be a preceptor too.
Yes.
I love it. Everybody's
It's
like,
fun.
"Oh, you got to take
Yeah.
a student. It's a pain in the ass.
Yeah.
They're going to slow you down." I said, "Well, actually, no. I'm going to teach them so good. Eventually, I'm going to be sitting down watching them."
Yeah, and we
which
have
is
a lot
cool.
of nurses that prefers not to have students.
Yeah, I've met a lot of people like that.
Yeah.
It's like
But
sharks,
I love
right?
It. I love students.
But
I think
they're
they're a big help too.
well, yeah, their help and like the thing that I liked about it was the effect that you have on their life. Teach them right and teach them to
Yes.
care. But more so, I was like, I could only touch 12 people a day, the dialysis patients. If I teach you, then you can touch 12, and if I teach him, he can touch 12, and I teach him, he can touch 12.
Just like COVID.
Yeah, like COVID, yeah. But I thought, like, if I could just get, like, some of the passion, like you mentioned, right? Like, don't do it if you don't have it. If I get
Yeah.
some of the passion over to them, I know I can teach them the skills, but if I can get some of the passion over, then how many patients am I touching, right? And that's the way why I really
Right.
loved it. And, I would just kind of throw something in your table of thought as you evolve, right? Like, how do you educate, right? Well, you can educate operations. You can educate medical device, right? Like, that's one of my roles. I educate in medical device. And it's a different world. It's healthcare,
Right.
but it's a different world. I don't touch patients in that setting, but the device that we're working on bringing forward will touch millions. So I feel like, okay, I'm part of something now in design and development that then turns into the education, like
Yes.
you mentioned, but it has the potential to impact more people than I've ever
Which will make a
imagined
difference.
touching. Right. And that's ultimately, I think, what I heard from you is you want to make a difference in people's lives. I think there are a lot of ways to do it, one-on-one at the bedside, teaching so that
Yes.
you can multiply and compound your effect. Maybe your skills are also in helping with some of the devices that you use in the stroke unit or the peritoneal dialysis devices, becoming more user-friendly for people to teach and for people to learn, right?
Right.
Because we know that there's not really a big market of competitors when it comes to like the cyclers for peritoneal dialysis, right?
Yeah.
There's just
I
like
don't see
two.
a lot of the new
There's
ones
two,
too.
right?
There's just like the old machines. I don't know if you've
Yeah.
seen those.
Yeah, I have. So
Yeah.
I would imagine you're probably working with the Baxter or
Baxter,
Yeah.
yeah,
So
that's the one.
what do they call that? The Freedom Choice or something like that. And then the Fresenius has the Liberty side. So there's
Yeah.
we don't see very much out there. Things are started. People are thinking about how to get
How to advance that.
and make them
it's
more
incredible.
user friendly, better for human
It's not
factors.
user friendly. It's not, honestly. But yeah, hopefully that would change. Because
But-
it would make our lives easier too as a nurse if we do have them on a cycler.
Yeah.
And if it's a lot of steps.
So does it feel threatening when people who need, and I know the answer to this for you because of the passion you have, but is there a fear from you as a nurse that if people are empowered too much, that they don't need you?
I think they'll always need us, no matter what the technology is out there. I think nurses are really important in healthcare.
Yeah.
As you can see during COVID, right? We were
Yep.
like really appreciated for a while.
But yeah, I mean, for a while, right?
For a while.
So
Because, we get the freebies, we get the lunch, we get the dinner, we get the breakfast, and then
Yeah.
we have like hotel foods
that's right.
coming in.
So and you
all
could stay for work, right, in different hotels as well.
Yes.
And now
So
it's
there was a
gone.
lot of benefits from during COVID.
Yeah.
But it died down.
Yeah.
Like I felt like I've never felt so important
I could say this. I could say the same. Like I got took into a COVID operation as running ops,
Right.
for testing, vaccination, telehealth, stuff like that, and I didn't like. I don't want a job. Like I like to just run my business, right? But I was like, what am I going to do? Say no when they need my help?
Right.
And there were so many people coming out there. Like you said, it's like I felt like that, and there were a lot of, like you said, freebies as well involved in that. Like we had restaurants open up that weren't open, and events and things like this. Everybody tested, and we were still doing a lot of stuff as a executive team running this operation because we were appreciated by people in the counties that we were helping.
Yeah.
Yeah. So it was. I never want to see it again, but it was one of those moments where you learn a lot about humanity. I'm disappointed to see that the superhero status has kind of died down, and
you don't see that, like, Ja. Yeah.
yeah, and that it's almost been de-glamorized.
Yeah, and you'll
to be
see
a
that
nurse.
nowadays as far as like nurse comedians, Nurse John. I don't know if you guys know any of them.
Yep.
Like they would address those issues too as a joke, but it's reality.
Yeah.
Like whatever they're addressing in their like comedy shows, those are all like
The
real.
life
That's
of
the real life of it.
Yeah.
Yeah. But like I said, if you're passionate with what you do, no matter what hits you as a nurse, you won't quit.
So Nurse Jaye, what's the most important thing that you can share with us as far as personalizing the journey, whether it be from perfect health and keeping it, or getting back to it, or self-managing?
Self-managing.
Yeah. What's the most important thing that you can tell us today?
I think everyone should just prioritize their health first, as far as being active, exercise, living a healthy lifestyle, diet, those things, and taking what like regular follow-ups with your doctors, like preventable stuff. Pretty much is what you have to do, because everything is like, a lot of these things are modifiable nowadays, that you have to actually step in and to actually do something for yourself to prevent any other issues.
Yeah.
Right? Like you're not gonna not take your blood pressure medication and have other issues, when this blood pressure medication alone can save your life. Like you have to take action for yourself.
Yeah.
Because a lot of times it's like you won't take action unless something really happens. Like they wait to that point, right, Paco? Right?
You're not telling me something, man? You're diverting to me when...
Yeah, he doesn't sleep.
Oh yeah, I know
that's
that
one thing. Just like a lot of modifiable stuff. Like you can do better. Prioritize your health. Health is wealth. That's what they say, right?
That's what
health
they say.
Is wealth.
Yeah. The older I get, I think the more I believe that, because I've only found a way to get wealthy when I'm older, and I feel like I got to keep healthy. Otherwise, I'm losing all these good years of wisdom that it's finally setting in my head. I really appreciate you coming and sharing with us. I'm excited about the same thing you're excited about, just your future as an educator. Definitely give you all the credit in the world for your your role as a nurse, and the journey that you've had from LVN through the nursing homes into, a very reputable organization, highly complex component of the healthcare system, and then with the special skills that we share. I am going to go back to the original thoughts, that I will probably still continue to muse on, because it's something that there's all these pieces for me in what you just said, sleep, exercise,
being active.
diet, active, and you're a mother. I'm a father. We're all parents here. I think that's a component that, like, when you think about the basics in life, right? There's this famous professor that said, like, the three things you got to put in your jar first are your health, your family, and your faith,
Amen.
Amen.
right? So, back to the health. Well, family's part of it, and I believe faith is part of it as well. Whatever your faith is, but
Yes,
I think keeping check on this is as important as this, and your veins and your lungs. Keeping check on your
Mental
mind and your
health
soul
is really important.
Yeah. So, I'll just kind of take my last words as like, let's focus on those guys. Make sure that we're I think it's aligned with what you're saying, but keep the priorities. I want a nice new car. I do, but I really want a better relationship with
it's
my
more
family
like
more than that.
Asking yourself your needs and your wants.
Yeah.
You want it, but do you really need it?
Yeah. Yeah.
That's what my husband always tells me.
Well, I need my health.
Yeah.
I need my family, and I need my faith. And
There you
I
go.
think hopefully everybody will agree with that. If not, make sure you comment, send us a question or a debate on this. Thank you for everybody who's still
Thank you
with
for
us
having
after the
me
entire.
today.
And Nurse Jaye, look forward to
Yeah,
seeing you in the
thank you.
future. Congrats on the first.
First podcast.
Yeah. And,
Unexpected podcast, guys.
have a good night, everybody.
Bye.
This episode has been brought to you by Dialysis Education Services.